If we get to a place where we can better predict who may respond to which drug and who may not be optimally served by sequential use of these drugs, we'll have a little bit better insight, meaning that we'll use one of the AR-directed therapies up front, but then move to subsequent therapies, be it chemotherapy or other novel agents. Right now, we're still stuck with a paradigm of not knowing that. We're still trying to work radium-223 into the equation, and whether or not it's used in patients, for the most part, prior to chemotherapy, in selected patients, or in those patients who've had front or second-line chemotherapy. All of that remains in flux. There are some trials that will give us some insight into radium-223 combinations with these next-generation ARs. It's not surprising that within a few years of rapid approval of multiple drugs that we don't really optimally know how to do sequence, but there are ongoing trials that are beginning to look at sequence and crossover. So I think over the next 5 years, even with the hopeful integration of new treatments on top of what we have, we'll have a better idea for many patients on how to manage them in a sequence.